I'd like to welcome everyone this afternoon to the 26th public meeting of the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. My name is Paul Plummer, and I serve as chair of PACCARB along with my co-chair that I'll introduce here in just a minute. Today, we have a rather abbreviated meeting to review the report out of a requested the report on infectious disease workforce incentives. We have a immediate action subcommittee that's a standing part of PACCARB, and we asked that subcommittee to make some recommendations around this topic. And so today we are here to discuss and deliberate and ultimately vote on the outcome of that report. And so we appreciate the work of the Immediate Action Subcommittee and the discussions that we've had in preparation of this report, all of the subcommittee reports efforts in doing so, and we look forward to discussing this more today. Without further ado, I'm going to turn it over to my co-chair, Dr. Jason Newland, for a couple of brief comments before we jump into discussing that report. Jason?
Yeah, thanks, Paul. Just appreciate the council and the subcommittee on all the great work. I think this is an important topic as we discuss ID workforce. If we just think of the current times with the WHO recently talking about the concerns around mpox, as we see elevation in certain pathogens such as mycoplasma in children, listeria outbreaks, the need for an ID workforce is ever present and is needed, and we know it's troubling when it is as low as it is. So I just like to say thank you to all of those who have been involved in this important work, and I look forward to our quick and fun discussion. Thank you.
Awesome. Thank you, guys. Well, thank you for the introduction, and I'll echo some of Jason's comments on the next slide.
Really quickly, Pyle, I'm going to go over some rules of engagement and roll call, and then we'll hand it over to you. Welcome, everyone. I'd like to thank Drs. Plummer and Newland for bringing us in this afternoon to our 26th public meeting. I'm Sarah McClellan. I'm the alternate designated federal officer for this advisory council, and I'd like to thank all of our attendees and stakeholders for joining us today. We also would like to thank and acknowledge those who provided written public comment via our CARB at HHS.gov mailbox. As always, those comments are shared with our council prior to the meeting. This advisory council was established via executive order in 2014, codified into legislation through the Pandemic and All Hazards Preparedness and Advancing Innovation Act in 2019, and formally reestablished under this statute in September of 2020. I'd also like to announce that our charter has just been renewed today for another 2 years. The goal of this council is to give the Secretary of Health and Human Services advice and recommendations to improve the programs and policies related to antibiotic resistance that would contribute to the overall health of our country. As a federal advisory committee, we are governed under the Federal Advisory Committee Act. As such, all 15 voting members are considered special government employees, or SGEs. All regular government employees, or RGEs, on the council represent the interests of their respective federal agencies, and both those groups are subject to conflict of interest regulations and vetting. Activities of the Advisory Council, including information gathering, drafting reports, and recommendation development, are performed by designated working groups. The working groups then report to the full council for deliberation and vote, which is what will be taking place today. As with all of our public meetings, this meeting is being recorded and will be available on our website at hhs.gov/PACCARB. As Drs. Plummer and Newland mentioned, today's meeting will focus on deliberating and voting on a resolution letter from the Immediate Action Subcommittee, which advocates for incentives to strengthen the infectious disease workforce. This letter is a continuation of recommendations made in the Pandemic Preparedness Report from 2023 and aims to address urgent need for more ID professionals, as highlighted in the Infectious Disease Society of America's presentation during our last public meeting in May. During the deliberation portion of the meeting, I will ask that you please raise your hand to provide comments. Ms. Haley Krem will be sharing the resolution letter and offer live edits should there be any during that time. This is a very tight meeting, so we will need to adhere to the time allotted for deliberation, and we ask that you please prioritize one thought per comment and keep them brief so that we can offer everyone an opportunity to speak. As always, we ask that you please keep your camera on and your line muted unless speaking. I would now like to take the opportunity to thank the team for their efforts to support the working group, the council overall, and in planning this meeting, especially Ms. Haley Krem, Dr. Zaina Francis, Miss Lauren Plain, and as always, our logistics guru, Miss Jennifer Adana. I'll now go through roll call for all of our council members. Please let us know if you are present by stating here. For alternate representative members, please identify yourself and provide the name of the principal you are representing today. Beginning with our voting members, our chair, Dr. Paul Plummer.
Here.
Our vice chair, Dr. Jason Newland.
Here.
Dr. Stephanie Black.
Here.
Dr. Claire Burbick.
I'm here.
Dr. Virginia Fate.
Here.
Dr. Susan Wong.
Here.
Dr. Jenny Kwan.
Here.
Dr. Brian Lubers.
Here.
Dr. Lynn Marks.
Here.
Mr. Armando Nahum.
Here.
Dr. Payal Patel.
Here.
Dr. Robin Patel.
Here.
Dr. Joni Sheftel.
Here.
Dr. Julie Simzak.
Here.
And Dr. Thomas Whittam.
Here.
Welcome all. Moving on to our liaison members. Dr. Carla Houston for the American Association of Extension Vets.
Here.
Dr. Padmini Srikantaya for the Bill and Melinda Gates Foundation. Miss Emily Wheeler for Biotechnology Innovation Organization. Dr. Francisco Zagmet for EpiX Analytics. Dr. Lucas Pantaleone for the National Institute for Animal Agriculture.
Here.
Dr. Elizabeth Dodds Ashley for the Society of Infectious Disease Pharmacists.
Here.
And Dr. Timothy Jinks for Wellcome Trust.
Here.
Welcome. Now for our regular government employees, please be sure to indicate if you are covering for a principal RGE. Do I have any representatives from the USDA? Anyone from the Department of Defense?
Hi, Paige Waterman.
Welcome, Paige. Moving on to HHS, anyone for ASPR BARDA? AHRQ?
Hi, Susan Henderson for Dr. Melissa Miller.
Welcome, Susan. CDC? CMS?
Jasmine Dinsa for Dr. Sherry Ling.
Welcome, Jasmine. NIH?
Kyungmoon for Dennis Dixon.
Welcome, Kyung. OGA? FDA? And finally, EPA. Great. With that, that concludes roll call, and I'll hand it over to our Immediate Action Subcommittee co-chairs, Dr. Payal Patel and Lucas Pantaleone.
Thank you so much, Sarah. Next slide. So thank you again for everyone making time for working on this, and to our committee for reading through and coming up with a recommendation. Next slide. In many of the reports that PACCARB has put together and the talks that we hear about, we often hear about the importance of ID professionals across the spectrum. We've just heard from Dr. Newland some current topics, and those topics are ever changing. Hard to pronounce new viruses. Currently, there's a round of encephalitis going on throughout the country. And to fight these different infections, we think it's really important to invest in ID professionals. That can include infection prevention and control program leaders, antimicrobial stewardship leaders, of course, across the One Health spectrum, managing emergent and endemic diseases, IDing and epi and treatment of zoonotic diseases, and then, of course, our most recent report with the pandemic preparedness. Next slide. I thought that this graphic is really important to highlight. If you look at the white area in this graphic, which was actually a paper by Dr. Walensky, this shows that every county with a white spot doesn't have an ID physician in that area. And so it's hard to imagine that most of the country is really sometimes understocked, underutilized by the ID physicians. We're trying to fight this with different ways like telemedicine, but our hope is that we can invest in different ways to build this up and fill in these white spaces. Next slide. The IASC has drafted a resolution letter as a continuation of the PACCARB pandemic preparedness report, and I will hand over to Dr. Pantaleon from here.
Thank you, Dr. Patel. And, really interesting map, and that is very telling about the problem that we have with the lack of ID physicians in the United States. So the recommendation for our subcommittee was based on trying to recommend for the federal government to develop and enact some incentives to really promote more ID professionals to enter the workforce and do the important work that they do as ID professionals. Next slide, please. So I wanted to, next slide, please. So I wanted to point out here the title. We, as a subcommittee, came up to 3 recommendations, but these are potential recommendations and incentives. And I want to point out the potential because we really, as a subcommittee, wanted to leave open the door for future or other potential recommendations that could come along to complement the ones that we are going to be discussing today. And of course, the main one for our subcommittee was to develop new CMS codes to really be able to charge for the services that ID professionals do. And also because there is a lack of filling up some of the residency programs and training programs for ID professionals. So in order to incentivize professionals going into training, instituting some federal loan forgiveness and repayment programs would be also paramount to improve the ID workforce. And also, we recognize these incentives need to be sufficient and also sustainable in time. So this is not something that we do, in the short term, but also in the long term and sustainable. So this is about all we have to say, this summary of our recommendations. So now we're going to enter the deliberation and vote section of our meeting. And I'm going to hand back the microphone to Sarah McClellan to lead us through that. And also, as Sarah indicated at the beginning, please feel free to raise your hand and provide your feedback. We are going to be doing live edits during our meeting on the letter draft that we put together. Thank you.
Thank you. We'll now move to the deliberation portion of the vote. Ms. Haley Krim will go ahead and share her screen for any live edits. And just to reiterate, Dr. Pantaleon, please raise your hand if you have any comments. Go ahead, Dr. Plummer.
All right. I just wanted to thank Drs. Pael and Lucas for bringing us this report and for the committee's hard work. The entire PACCARB has received the draft of this, and so really, look forward to the discussion from that. Look forward to your comments and questions. But from my perspective, thank you for the hard work. I'm pleased with where we're starting on this, and so look forward to the continued discussion. So thank you to the committee and our chairs, and now I'll turn it over to Lynn.
Thank you. Yeah, I just wanted to build on the comments about this being a start. I don't think any of us believe that these potential recommendations will solve the problem. I would encourage professional organizations, for example, IDSA, ASM, many others, to look to their membership to understand what kind of additional incentives would be necessary in order to build the workforce. I see this as a ongoing work effort. It won't be solved overnight. The residency programs didn't fill, and that will take some time to turn around. That's a vast map of absence across the country. So this is a journey, not a quick fix. And I would encourage those societies to help us help them by understanding better what would motivate more professionals to enter the field of infectious diseases broadly. Thank you.
Thank you, Doctors Marks and Plummer. Any other comments? Going once. Up, please, Dr. Pantaleon.
Yeah, I just wanted to highlight, as a veterinarian, the One Health aspect of the letter, and I think is very important for ID physicians, not only to provide the important role that they play in order to provide patient care, but also how we can work together across disciplines with a One Health approach. I think that is a very important part of what ID physicians do, and veterinarians as well. So I think we need to keep that front and center as well. Thank you.
Thank you for that comment. Any others?
This is Susan. I'm sorry, I can't figure out how to raise my hand, but I did put in a suggestion earlier, but it looks like it was not included, and it was an edit to one sentence, the one that says ID physicians are among the lowest paid physician specialties, and then I think there was just a clause that I put into an email that said that they are often lower, they are lower than primary care. And if we could just institute that, I think it was accepted by email, but I don't see it on this version.
Yeah, I'm happy to respond to that, Susan. As part of the discussion that kind of came after the fact, there was some concern about this comparison between ID physicians and other physician specialties, that we didn't necessarily want the finger pointing involved in that, but I'm happy to open that up for a broader discussion.
Yeah, so I just want to clarify what you said. And we're not comparing across specialties at all. We're saying that this specialty makes less than primary care. And that means there's no value to go into why train further into a specialty when the generalist makes more than you? And I mean, and it's well documented across, I think we all receive those Medscape scans. There's only one or two specialties that are less than primary care, and ID is one of them. So to me, it's very different. We're not pointing fingers. We're saying there's no value to train. You train longer for less pay. And I think it's a really important thing to say, because if someone in the government is just looking at it and says, we're lowest paid, what really does that mean to me? The point isn't that compared to other doctors, we're paid less. What we're specifically saying is there is no value to train longer to make less.
So Susan, would it be appropriate to maybe put that point in as an expansion on this sentence?
I would urge us to put something there related to that, because it's a very important concept.
So Haley,
go ahead, Sarah.
I was going to say in that section, we can say ID physicians are among the lowest paid physician specialties in the US. And then something along the lines of, disincentivizing those to kind of join the specialty or like, that's the main point, right? Right.
So added training to become an ID physician generally results in less pay than generalist salaries, or, you can fix that last part, but I want to call out the fact that we're talking about spending more time training to get less pay than non-specialty physicians. Can we, I'm looking at everybody else who's better at English crafting than I am, but can we come up with something that would be acceptable and not seen as rude?
Comparison.
I don't think any of us are trying to be,
well, to your point, it's much more about the kind of cost per training, right? It's a lot more training, it's a lot more intensive, and it doesn't result in an equivalent amount of compensation for that
Right,
training.
so like an added training or added specialty training in infectious diseases generally results in lower pay than non-specialty physicians, right? So, something like that. That way we're not picking on any specialty.
Yes.
We're just saying the training value is insufficient.
So maybe we begin the sentence with added specialty training.
Added specialty training.
Maybe just
It
put
looks
a
like
period after US and then create a new sentence.
Dr. Marks, did you have a comment on this?
Well, first of all, I think it's an incredibly important point, and I don't know if the term subspecialty would help. In other words, if your specialty is internal medicine, your subspecialty would be infectious diseases. So there's no value in moving from pediatric primary care as a specialty to the subspecialty of pediatric infectious diseases. I don't know if that will help.
Dr. Plummer?
Maybe the way it's in there is okay. I was going to suggest something at the beginning of the sentence like ID physicians or becoming an ID physician requires additional training over that of generalist, and while still being among the lowest paid physician specialties or something like that. Trying to draw out the increased training, but remaining as the lowest paid. But perhaps the way that we currently have it crafted is better.
We could even remove the word added. Subspecialty training in ID generally results in lower pay than non-specialty physicians, I guess, or I don't know if it's physicians.
Dr. Zagman?
I think that addition makes a lot of sense. I was looking from just the numbers perspective. I don't know if it's really true that a general physician will make less money after going into the subspecialty. I'm thinking as a longitudinal life of one doctor. As opposed
it's
to
well
on average.
documented. Actually, that's well documented. I don't.
So they will make less money after.
Yes.
After this.
Yes.
Okay. Then
Starting
it's
salaries
fair.
are lower. Ending salaries are lower.
So you start as a general practitioner making $1, do a specialty, you will make then 90 cents.
Yes.
Okay.
Yes.
Yeah. Then
Well
I think it's accurate to say that. Okay.
Yeah.
So as it reads now, we have ID physicians are among the lowest paid physician specialties in the US. Subspecialty training in ID generally results in a lower pay than non-specialty physicians.
Maybe get rid of A.
In lower pay, okay. Does that sound good to everyone? Do we have any comments or other wordsmithing on that point? Go ahead, Dr. Marks.
Well, again, it's the non-specialty thing. It may be just, I think
Okay.
primary care is where that started.
Either generalist or primary care.
Right.
Okay. Does anyone have objection to including primary care in there?
Nope.
Great. Dr. Black, I saw your hand was raised. Do you have a comment in relation to this, or was yours a different comment?
It was a different comment.
Okay. Are we all good to close this point out? Any other comments on these two sentences? Okay, Dr. Black, the floor is yours.
I was just going to comment that in highlighting the importance of ID professionals and the program leadership that they play, in addition to infection prevention and control and stewardship, they do lead public health programs. And I think that the spirit of that is captured in managing emergent and endemic diseases. I mean, as people have pointed out, with vector-borne disease and having CDC command, there are infectious disease professionals who have those public health roles. So as a representative of public health, I just wanted to raise that because we highlight the roles played by in infection prevention and control and in stewardship.
Would you like a
talk about
specific...
two vital operational roles? I thought we
Okay.
could consider adding, lead infection prevention and control program, You could say infection prevention and control, antimicrobial stewardship, and public health programs, or something like that.
Stephanie, the question I have for you is infection prevention and control. Usually it's specified that it needs to be an ID professional, same with antimicrobial stewardship. In public health departments that oversee infectious disease response, is it specified generally in most states that it needs to be an ID trained person?
It does not have to be, but it's certainly a benefit, I think, to have infectious disease professionals in that role over, communicable diseases in those situations. But it is not a requirement. I mean, it's another example, frankly, of infectious disease physicians being paid the same as, that isn't even necessarily recognized with pay.
I'm gonna have to jump in really quickly because we are tight on time.
Okay.
So I would say if there's a specific edit you would like us to make to the sentence, Stephanie, can you just give it to us kind of word for word so we can quickly pop it in and see if it adheres to or everyone else agrees with it? Otherwise, is this something that we can kind of add in additional kind of context later as this letter goes out?
I was just suggesting in the sentence that starts with ID professionals lead infection prevention and control programs that you might list infection prevention and control, antimicrobial stewardship, and public health programs.
Okay. Does anyone object to the addition of public health programs into this sentence?
Then you would have to add 3 potentially vital operational roles.
That's fine.
And that's fine if you all don't think that it rises. I just wanted to raise the issue.
Does anyone have an objection to adding that in?
I think we need to be careful because it says vital operational roles that are required. So, antimicrobial stewardship programs and infection prevention are required of all hospitals, but the added of the public health would be in the wrong place. So I wonder if it should be its own sentence. Or under additionally, ID professionals play a critical role in public health response.
Yeah.
Maybe it's there.
Yeah.
That was going to be my suggestion.
That's great.
Yeah, excellent.
I agree with that.
Does that work for everyone?
Yeah.
In the comment, Dr. Marks suggested a reference, Susan, for the addition below about pay. That's something we can add after the meeting, but if you could please send us that citation. I think that would help bolster.
Yeah, so for everyone, the ones that I know are the ones that come out every month from Medscape that show the ranking.
Okay,
I don't know if there's a publication, but are you allowed to cite Medscape?
We can look into that. All right, we need to move to a vote. Are there any other major comments or changes that anyone would like to raise at this time? Okay. Seeing no other raised hands, we're going to move to the council vote. When I call on your name, please respond yes or no for transmittal of this resolution letter as is to the Secretary of HHS. Keep in mind, we will add in the citation as appropriate for the addition we made today. I'll be calling on our SGE members to vote. Are we ready? All right. Our chair, Dr. Paul Plummer, please provide a yes or no on whether you would like to see this transmitted.
Yes.
Great. Vice Chair, Dr. Jason Newland.
Yes.
Dr. Black.
Yes.
Dr. Burbick.
Yes.
Dr. Fate.
Yes.
Dr. Wong.
Yes.
Dr. Kwan.
Yes.
Dr. Lubers.
Yes.
Dr. Marks.
Yes.
Mr. Nahum.
Yes.
Dr. Payal Patel.
Yes.
Dr. Robin Patel.
Yes.
Dr. Sheftel.
Yes.
Dr. Simzak.
Yes.
And Dr. Whittam.
Yes.
Excellent. That concludes our deliberation and vote. As it stands, we did not have anyone sign up for public comment. If that has changed, Jennifer, please let me know.
No public commenters.
Excellent. I will now hand it back over to Doctors Plummer and Newland to close us out on time.
All right. Well, I appreciate this. Thank you, everybody, for taking 30 minutes to join us here. Seems like a quick time, but I think successful because of all the hard work that the Immediate Action Subcommittee put in on this and working to get this prepared. So, final thanks to both PACCARB staff and everything from behind the scenes. The committee, our chairs of the committee, and I will turn it over to Jason for his final comments and look forward to seeing you all at our next meeting.
Nothing further. Have a wonderful Labor Day. Thanks, everybody.
Thank you, everybody. Have a wonderful day.
Produced by the U.S. Department of Health and Human Services.